Hello, my name is Sam Ord, and this is a lecture on Doppler Principles and instrumentation. It's not perfect, it's not complete. There's probably some more stuff regarding the instrumentation. I'm not sure how relevant that is for clinicians doing their exams, but anyway, this is 20 minutes on the Doppler Principles and instrumentation, and then of course there's more. So during this lecture, I hope to discuss the Doppler effect, which was first described by Christian Doppler back in the 19th century. We'll talk about the basic Doppler principles and how they relate to pulsed wave Doppler, continuous wave Doppler, and color Doppler, and how the instrument makes some of these images that we see and we're using every day. So the Doppler effect is the effect that you have when you're standing on the road and you hear that ambulance come past you, and it starts off with a higher pitch and then goes to a lower pitch sound. And it's exactly the same principle that we're using to detect movement and flows in the body. So the Doppler effect is the change in frequency as that target moves towards you. So using that ambulance analogy, as the ambulance is moving towards you, the sound waves are compressed, and that means they have a higher frequency, which means that they sound higher, as opposed to when it's going away from you. When the sound waves are they're stretched out, the frequency is less and the sound is lower. Exactly the same principle in echocardiography or any kind of ultrasound looking at blood flow. When we send out a transmitted pulse, it then gets reflected off let's use for example, a blood cell. If that blood cell is moving towards you, that means that the reflected ultrasound will come back to you with a higher frequency, and comparing the transmitted to the received signal, you can get an idea of what the Doppler shift is. And using an equation, you can start trying to understand what the speed might be of that object moving towards you. If the object is moving away from you, the Doppler shift will be less, obviously, because you've got a lower frequency in the received signal compared to the transmitted. And if the object is stationary, or if the object is moving exactly perpendicular to you, you are not going to be able to tell what the movement is. So this is all dependent on the Doppler equation. So that's saying that if you take the difference between the returning frequency minus from the transmitted frequency, that is going to be equal to 2 times the transmitted frequency times the velocity of the structure, blood in this case, times cosine theta. It's really important that we remember it's a cosine theta, as I'll show you in the next slide. And all of that is divided by the speed of sound in blood, which is 1,540 meters per second, as an assumption that the ultrasound machine makes. So that cosine theta is really important because this Doppler equation is angle dependent. Okay, so cosine theta, as you can see up at the top there, when theta, or the angle, is 0, cosine is considered to be 1. Now in echocardiography, when you're using that phased array probe, the machine just assumes across the board that you are absolutely perfectly in line with the movement of that structure. So it assumes that theta is 0, so you are perfectly in line. Or of course, you're sometimes not. If you have theta up at close to 90 degrees, it's 0. And that's why, again, as we said, that we cannot pick up the movement of a structure if it's at 90 degrees to us or perpendicular, because that's 0. That means cosine is 0, so you can't detect any movement based on the Doppler equation. Okay? In terms of the the error that you can make in your velocities, you can see that from the graph below with the degrees that you're out when you're measuring it, as opposed to the error percentage. And you can see there's this kind of exponential rise when you start hitting about 60 degrees out, where you start to get massive errors that come into your equation. And so we have this kind of ballpark thing about when theta gets above 30 to 60 degrees, you're going to start to get significant error coming into your analysis. And if you're doing some of this vascular ultrasound, you can actually change the gate that you're looking through at the to try and optimize for some of this. So the more you change the gate, it senses the angle difference that you're looking at, and it accounts for that in the analysis for the movement of the blood. So what does it look like? Well, the main ones that we're going to look at are the pulsed wave Doppler, and color wave Doppler comes into this. We'll discuss this in a moment. But so mainly we have pulse wave Doppler and continuous wave Doppler. So pulse wave Doppler is such as the graph on, such as the picture on the left there, where you get this kind of envelope that's formed, and the echogenic sort of portion of it, or the envelope, gives you sort of the range of velocities that are seen. So a good pulsed wave envelope is something that has a very sharp, delineated edge, such as, I think this is a pretty good Doppler signal that we've got there, pulse wave Doppler signal. So it's got a nice sharp edge, and we have a nice sort of black inside to the envelope, which means that it's not picking up any movement in those velocities down there. So a nice sharp edge, okay? And what pulse wave Doppler is all about is this gate that you're putting. So you put a gate at a certain area, and you can see, if you can just make out on the image there, it's at the sort of the inflow to the left ventricle. And it gives us a gate. So you're asking the computer to just tell you about the movement that's happening of the blood, or whether it could be tissue as well, but just in that certain portion of what you're looking, hence the pulsed wave Doppler, and you're just looking at the gate. So you're getting some spatial location. That's the advantage of this imaging modality, is that you're actually just looking at a particular space in time. But the problem is that you can get what's known as aliasing, which we'll discuss in a moment, and that's basically the upper velocity detection limit that you can sense with pulse wave Doppler, which is about 1.5 to 2 meters a second. Continuous wave Doppler is where you don't have a gate that you're looking at, and you're looking at flow anywhere down one line of sight. So you put down your cursor sort of line down one area, and you pick up all movement along that line. So typically you have a curve that looks, just this example here, where you've got the envelope is completely filled in, because you're getting a huge range of velocities that you're picking up. But what it is good at doing is that it can tell you what the highest velocity is, so that there's no aliasing with continuous wave Doppler, and you can pick up to 4-6 meters per second flows that are coming through. So this is really important when you're looking for things like stenosis. The problem with continuous wave Doppler is that there is no depth discrimination. Okay? They send, in terms of the instrumentation, it's slightly different between the two. With the pulse wave Doppler, you just have a single transducer, so the element is both sending out and receiving the signal. With continuous wave Doppler, because it is continuous, that means that you've got one section that is continuously sending out the sound waves, and you have other sections that are continuously receiving the sound waves. And again, doing the Doppler equation, assessing the difference between the frequencies to determine the blood flow. So first we'll start with talking about the pulse wave Doppler. So this is obviously all to do with pulsed ultrasound. So similar to B mode or M mode imaging, we're using pulsed ultrasound. So that means that we send out short pulses of ultrasounds. And they are going to have a certain length depending on how many wavelengths you've got in there. Typically with pulsed ultrasound, it's like between 5 to 30. And depending on the frequency you're using, and again how many waves that you have in there, you're going to have a certain pulse length. And if you were thinking that in terms of wavelength, in terms of the actual time that it takes time it takes for that pulse, that gives you a pulse duration. Now again, the echo machine, depending on where you put that pulse, it's going to send out a pulse, and it's only going to listen to the sound waves that are coming through at that depth. And that's because the ultrasound machine knows that that sound wave, it assumes, is traveling at 1,540 meters per second. And so you've got that 13 microsecond per centimeter rule that we discussed in one of the first lectures. So that machine then knows that if it sends out a pulse, and I'm imaging at, say, a depth of 10 centimeters, it's going to wait 30 microseconds times 10, so about 130 microseconds, just to listen in that certain gate length. And it's only going to listen at flows that are coming back from there. So that's all going to be, that's how we're going to get that depth recognition. This is going to be obviously dependent on the pulse repetition frequency. So that's about how many pulses, which is the sending out the pulse as well as the listening for the echo. So it's going to depend on that pulse repetition frequency, which is the pulse repetition period as well, which is about how that number of kilohertz over 1, that pulse repetition period in milliseconds. The duty factor is the amount of time that pulsed ultrasound is going to be listening for. For B mode imaging or M mode imaging, it was about 0.001 to 0.1%. For Doppler, it's more like 0.5 to 5%. So I guess that's important to know. And this is where this theory of Doppler aliasing comes in, which is important to know about. So we said that pulse wave Doppler has a limit to the velocities that it can be determined, and this is what aliasing is known at. And aliasing is essentially what happens because different signals can be indistinguishable above that velocity. The exact velocity that we're looking at, which we can determine where we're going to get aliasing above that, is known as the Nyquist limit. And the Nyquist limit is the pulse repetition frequency divided by 2. So that's the sampling rate, or the pulse repetition frequency of that received echo divided by 2. Again, above that, we're going to be unable to distinguish between different frequency ranges, and we're typically at about 1.5 to 2 meters per second is the limit. Okay? On the actual machine, it's going to be displayed as this kind of wraparound, or it's almost going to show in the opposite direction. Again, I'm going to show you images of all of this. And the last thing to remember is that your pulse repetition frequency varies inversely with depth of sampling volume. So if you want to increase your Nyquist limit, that means that we're going to have to increase our pulse repetition frequency, which means we're going to have to reduce our depth. And again, I'll go through all of this in the next few slides. So first of all, let's just consider the received frequency that we've got in the top there. And it's all about the minimal number of sample points that we can use, which is based on the pulse repetition frequency of the frequency of that received sound wave. So if we consider just one sound wave that you've got there at the top left on that image, if we're picking it up on that just one sound wave, if we can sample it twice at any stage, we'll be able to pick up what the frequency is of that sound wave. Now compare it to the example on the bottom, and this is where we're going to get Doppler aliasing. Basically, it is going to be difficult for us to distinguish whether we've got a frequency which is of that blue line or whether it's the frequency of that red line. We're not going to be able to tell the difference if we're sampling it because we are sampling it less than twice a wavelength essentially, or less than twice a pulse repetition frequency, or less than half the pulse repetition frequency, excuse me. So again, if we've got the frequency of our received signal, it's less than twice their fundamental frequency, then the sample signal can appear to have a lower frequency than the original, such as that red line compared to the blue line in the lower cartoon there. That's what aliasing is. Okay? I'll show you an example now. So let's look at this. Let's look at this image, and so this patient is going to have some form of obstruction that's happening there at the LVOT level. Okay, so we're getting some form of systolic anterior motion of that mitral valve. And what it looks like when you stick the pulse wave over that area is you get this huge sort of, just after the A wave there, you're going to see that we're getting, during systole, this huge, sort of huge, here it's in yellow, this great big signal that comes all the way down, and it goes from the top, from our baseline, all the way down, and it goes straight through the bottom of what we're being able to pick up, which is at about 2 meters per second. What do we want to do in this circumstance? Well, we want to use continuous wave Doppler. And here on the continuous wave Doppler, we can see the entirety of that envelope. And we can see that envelope is reaching up to sort of 4.5, 5 meters per second. So what we were picking up with the pulse wave Doppler, we are only picking it up to about 2. We're getting that wraparound phenomenon that happens. So we're going to be able to see that curve come back from the top as well. And so what are the ways that we deal with aliasing if we want to be able to pick up structures that are moving faster than that? Well, we can image at a shallower depth that we discussed. We can decrease the frequency. And that's because the pulse repetition frequency is inversely proportional to the depth of the sample volume and the frequency. Okay? You can change the baseline. So you can move the baseline up to try and pick up, up or down, to try and pick up the sort of entirety of the envelope in that volume. And then the final thing, which is probably the most commonly used, which is just using continuous wave Doppler. Okay? Because that's going to be able to pick up much greater speeds because it is not limited, it doesn't give you any depth recognition, and it can pick up higher velocities because of that. All right. So how about color Doppler? So color Doppler is, we derive this from pulse wave Doppler essentially. So it's using this what's known as a BART phenomenon. So that means that it's blue away, red towards. And that means that any structures that are moving towards you look red, and any structures that are moving away look blue. You can flick this around, but this is the most commonly presented way that it is described. And what we're trying to get is, with color Doppler, essentially the computer sets up multiple gates within the sector that you put on the screen. And it gets an idea through sort of multi-gating autocorrelation, basically, as it averages whether that's blood is moving towards or moving away, and the velocity that it's doing it with. And it tries to average that all together to give you some sort of, to give you some concept of the movement of the blood in there, and it visually. You can have something called variance, which is shown in this cartoon on the right, which is essentially a variance is a way to get a measure of spectral broadening, or whether you're getting lots of sort of multiple different velocities that are happening around that area. So it gives you an idea of sort of chaotic flow, if you like. One of the problems with doing this is that it needs to have more processing done, so this is going to reduce your frame rate. And the way that they try and show this variance is often with like a green hue. So you can see the difference between the spectrum on the left cartoon here, which just has the red and the yellows above, and the sort of blues and the light blues below. Whereas with variance on the cartoon on the right, we can see when you're getting towards the higher flows, where the turbulence or chaotic flow is happening, that's when we're having this kind of green hue that comes into the top of the spectrum, if you like. Okay. So what are the differences between color Doppler and pulse wave Doppler? Well, you're going to be getting lower frame rates. It's not going to be as good at being able to detect slow-moving blood, because it is less accurate in determining Doppler shift. And that's all because of this autocorrelation, where you're kind of getting this averaging over a specific gate to do it. So if you're looking for accurate estimation of blood flow, particularly slow-moving blood flow, and you want to get the maximum frame rate, you must use pulse wave Doppler. But color Doppler is very important because it gives us an idea visually of blood flow and potentially chaotic movement if you're using variance. So I'll just mention a little bit about imaging with color Doppler, and as we said, we know that color Doppler greatly reduces your frame rate because you're showing both the B mode, or the brightness mode, the 2D picture, as well as the color Doppler. So you're going to want to keep your color area to a minimum, I think is the first one, about trying to optimize your color Doppler imaging. And then just the other things that are important is to look at both gain and your scale. So let's use this as an example. So how severe is the MR? Well, using this color scale, we can try to crudely change our Nyquist limit, if you like. And what we can see here is that we're trying to pick up at 0.36 is where the Nyquist limit is essentially at, so 36 centimeters a second. Whereas we know that probably the blood flow from mitral regurg is going to be going higher than that. So what we're seeing here is you get a lot of variance in there. You're getting maybe an overestimation of the blood flow that's happening because you're concentrating on slower moving blood as well. So depending on the scale, you can actually overestimate the severity using color Doppler of what mitral regurg is. Let's have a look at this example now, where the scale's then increased to 75. And you can see that the whole sort of sector, the amount of the mitral regurg looks much less based on the color Doppler there, and that's because we're aiming at higher moving blood now, and we're getting less variance. Let's turn it the other way and go to the extreme the other way. If we have the scale down at 0.8, you can almost see that the color flow fills the entire left atrium. You're getting horrible variance that's going on. And I guess I'm just using it as an example, showing you should be somewhere in the middle of these. And it's important to try and make sure with your color settings that you have the highest frame rates possible. You're not over gaining or over amplifying the image. You've got to check your color scale to try and optimize for the velocities of concern that you're looking at. So with things like mitral regurg, you're aiming at a higher level than if you're looking for something like a patent foramen ovale, where you'll be looking at lower flows. So you'd be wanting to decrease the scale for that. Okay? So it's all about maximizing it for the velocities of concern. And the final thing that's a big sort of pet hate of mine, which I think is trying to use color Doppler for estimation of valvular regurgitation severity. I'm guilty of it, probably as anyone else, because it's quick and it's simple. And trying to use quantification through using things like the continuity equation and things, it takes more time. I think if you're in any doubt of the severity of regurgitation, or it doesn't make sense when you start considering other factors. As an example, if you've got mitral regurg, if you're thinking that if you're seeing significant pulmonary hypertension, you think that might be from the mitral regurgitation, but based on your colour Doppler you think it's mild mitral regurg, something's not quite fitting in there. And this is again the importance of trying to look at the entirety of the echo findings and not just concentrate on one point. And the one point you shouldn't concentrate on maybe is the colour Doppler. You know, if you're worried about maybe you've got moderate or severe regurgitation, you have to calculate it. I think just using colour Doppler for quantification is lazy and potentially dangerous. And if you're looking at you know, serial measurements, looking at someone if their regurgitation is worsening when you need to replace their valve, for example, you must know how that's how much or what the regurg volume is, etc., as it goes on. So I think we owe it to our patients to quantify accurately as possible, and that's getting an indication maybe of the colour Doppler of the severity of it, but you must go on to doing calculations after that. I hope that makes sense. So in summary, we discussed the Doppler effect and the importance of knowing that you've got cosine in the equation, and that's where the angle dependence comes in. The echo machine is assuming that to be 0, so you need to try and get as accurately as possible to being down the line of the structure that's moving as possible. The main things we're using are pulse wave Doppler, continuous wave Doppler, and colour Doppler with or without variance. For pulse wave Doppler, this gives us the specific movement of something in a particular area, so it's giving us some kind of concept of spatial movement, but it's limited by aliasing, by the Nyquist limit, which is half the pulse repetition frequency of the received ultrasound wave. Continuous wave Doppler has no Nyquist limit. We can pick up much higher flows, but the problem is that it's not depth specific. So we only know what the movement of blood is along that particular line. We don't know where on that line. And with colour Doppler and variance, I think it's important to try and optimize your colour Doppler imaging to make sure your box is as small as interest, that you've maximized it for the frame rate therefore, and you're also trying to optimize both the amplification or the gain of that image as well as the actual colour Doppler scale for the flow of interest that you're looking for, and that will give you the most accurate sort of quick estimation of what the flows are in that area. And there are the references, obviously again extremely useful, and I encourage you to read those. I hope that was useful. Thank you very much.